Well, good evening, everyone. Welcome to Banff again. This is our virtual Banff Fellows Forum, our second live Zoom session. So thanks to all of our presenters. We've got a great lineup of good abstracts today. I've got a list of everyone that's going to be speaking today, and we're going to try to stick to the time. We have about 4 minutes for each presenter, followed by then about 5-minute question and answers. Obviously all of you are very familiar with Zoom now. You can enter, just like last time, your questions down at the bottom in the chat box. Dr. Ryan Spiker is my co-moderator tonight, and Ryan's going to be in the chat box there answering questions, and he's going to highlight some interesting ones and bring them up during our 5-minute breakout sessions. So that is the lineup for today. I just wanted to remind everyone again to please keep your microphones muted during this talk if they're not presenting. Obviously, to send in your question and answers or your questions in the chat window. And we're going to go over those and get back to in as didactic of a manner as we can. Just as a reminder for our fellowship directors, we have that score sheet that you've all received, and I'd like to, or she's asked me to ask you to please fill that out and get that back to her ideally after the session today, so we can rank our abstracts and award our prizes to the best abstracts. In terms of some upcoming events, we've got still the fireside case discussions, and that's going to be on Thursday. That's going to be a lot of fun. It's usually one of the highlights, certainly for me, but most importantly for the fellows, I think, at the actual Banff meeting, and I'm looking forward to this fireside case discussion. And please have your cases, fellows, prepared and share them with Chi. Just as a reminder, you will have received from Chi an email with this link. DePuy is putting together a session for the fellows just to talk about some of the challenges of COVID-19 for a lot of young surgeons and what DePuy is doing to try to help with our fellows in this challenging time. We also have for upcoming fellows webinar a presentation by Dr. Mundis and his group on basically how to transition into practice. And so that's going to be an exciting topic, and that's again one to mark down on your calendars. That's June 9th for that, so please save the date. So that's it. So without delaying anymore, we're going to get right into some abstracts.
All right. I think you might have to unshare your screen so I can share mine. Okay. Good evening, everyone. Can everyone hear me? Yes. Okay.
Yep, we can hear you.
My name is Brenton Pennycook. Oh, thank you. My name is Brenton Pennycook. Thank you for the opportunity to present some of my preliminary work on machine learning algorithms for prediction of patient-reported outcomes in advanced stage patients with grade 1 spondylolisthesis. This work is a composite of work done with the QOD, which we'll talk about a little bit further. I have no relevant disclosures. So as we all know, there are a couple of things that are certain in terms of projection over the next 10 years. The first of which is that the population in the US, at least, will continue to grow at about 12% increase by 2030. The second is that the composition of that population increase will also change, with patients or people over the age of 60 composing 26% of the population, as opposed to around 21% currently. And this is of particular importance to us as spine surgeons, as we're the ones who are typically treating a lot of advanced age patients. And as we know, there's some variability to how different spine surgeons treat elderly patients due to a concern that as patients get older, they may not have as favorable outcomes with certain procedures. So our objective was to predict the expected change in Oswestry Disability Index, NRS leg pain, and NRS back pain at 1 year and 2 year after posterior spinal fusion for grade 1 spondylolisthesis solely as the function of age. And ultimately, our goal is to develop a tool that will better inform clinical decision making and also inform the preoperative discussion with patients. The QOD is a composition of multiple different sites, each that give their patient outcomes to a unified registry. And so we queried the QOD for specifically patients who had undergone a 1-level decompression infusion, posterior decompression infusion for grade 1 spondylolisthesis. And we chose to use a random forest algorithm and controlled for a number of specific features, including baseline ambulation, intervention, gender, etc. So ultimately what we found is that 411 patients were eligible for this experiment. And what we ultimately found was that around 63 years of age, there was a decrease in the expected reduction in ODI as the patients aged and approached 100. We again found the same pattern for NRS back pain and NRS leg pain, though the morphology of the graph was somewhat sinusoidal for leg pain. More or less the same, that as you get older, your expected change in reduction in NRS leg and pain reduces as you age. We again saw this at 2 years, and interestingly, if you see our y-axis here, the difference between a 40-year-old NRS back and an 80-year-old NRS back is only about 0.2 points on the NRS back pain scale. So whether or not this is truly clinically important in terms of a difference in reduction in back pain is unclear right now. So ultimately, we're able to use a machine learning algorithm and the QED spondylolisthesis module to predict the expected PROs at 1 year and 2 year as a function of a patient's age. And we found that as patients age beyond the age of 63, generally, their expected reduction in pain and disability decreases. So ultimately, our next steps are actually, right now we're predicting along a continuous outcome. Our goal is actually to create a multi-class, of maybe 4 outcomes where you have an ideal outcome of maybe at least a 4-point reduction, a less ideal outcome of 1-point reduction, and no change, if not worse. And we think that this will make our prediction algorithm more robust ultimately and more accurate. And secondly, we plan to do some prediction in terms of dose response curves, where seeing if we can predict that as you age, how much is your age related to your change in expected outcomes. So thank you.
Thanks very much, Dr. Pennycook. That was excellent. Our next speaker is Dr. Molina at Johns Hopkins. Can we share his screen?
Okay, sorry, unmute. All right, good evening. Thank you again for the AO Spine Fellowship Committee for having me here tonight. I'm currently a fellow at Johns Hopkins. So to get started, hold on a second, looks like I'm having. This evening, I'm going to be talking about a study that we conducted at Rush in collaboration with Hopkins. It's a novel augmented reality head-mounted display neuronavigation platform, and we evaluated it in perspective of using accuracy and precision analysis for the placement of percutaneous pedicle instrumentation. This was a cadaveric study. As a main disclosure, I do have a significant tie to this technology. I was one of the original clinical developers, and I'm now one of the senior medical advisors for the startup company that manufactures this technology. So when we set out to develop the system, we wanted to bridge two main pitfalls that we saw in conventional computer navigation that lead to procedural inefficiency and potential for technical errors. The first being attention shift phenomenon, which is the requirement of having to look at a remote display for your neuronavigation rather than having the ability to look directly at the patient while you're placing the instrumentation. Similarly, we were also frustrated by line of sight obstructions that occur when the remote tracking camera is not able to see the registration frame or the tracked instrument or the end effector on the robot, and you lose live navigation. And this can be also predisposing to technical errors, workflow inefficiencies, etc. To mitigate these errors, we set out to miniaturize an entire navigation system in a head-mounted display with an integrated graphics processing unit. Very importantly, a tracking camera that's integrated into the headset, so there's no remote tracking camera, and rather the camera is internal to the headset, and you have the complete elimination of external line of sight obstruction. Similarly, we have a direct retinal display that overlays in a translucent fashion all of the relevant navigational data onto the surgical field. So what you see is a patient individualized 3D bony segmentation overlaid over that patient's real anatomy, whether you're open or percutaneous, and you have floating axial and sagittal projections to get an ideal tool trajectory and ultimate hardware placement. So in terms of the study, we placed all of our instrumentation percutaneously. 5 cadaveric torsos were procured, placed the registration clamp at L2, used either an arrow or a Zeem for 3D image acquisition pre-procedurally, and instrumented the cadavers from T5 to S1 for a total of 113 implants. 20 were Jamshidi needles, 93 were pedicle screws. This is the registration marker that we place prior to the 3D spin. They're then replaced for reflective markers. As you can see them here on the navigated tool and the registration frame. In terms of our clinical accuracy as graded by the Gertzbein scale, which really refers to having a less than 2 millimeter pedicle wall breach, we had an excellent total insertional accuracy of 99.1%. It removed the Jamshidi data. We have a total of 98.9% pedicle screw insertional accuracy. If you remove the lumbar place instrumentation that had 100% insertional accuracy, we see a 97.9% thoracic percutaneous pedicle screw insertional accuracy. And what this really means is that out of the 93 pedicle screws that we placed, only one of them was misplaced. It was a pedicle screw at T6 in a 3.7 millimeter pedicle, and it had a 4 millimeter medial breach that you can see in this image here below. But I think most importantly for this paper is the discussion of precision, because you can have high clinical accuracy, meaning that the pedicle screw implant is in a clinically accepted position, but it doesn't tell you about the precision of in a clinically accepted position, but it doesn't tell you about the precision of the system, its fidelity. And what that really refers to is, does the implant lie in the exact same position where you thought it would be in your virtual environment, on your pre-op planning or your intra-op virtual position? Because that's really how much confidence the system gives you. What you want to have is high accuracy, high clinical accuracy, and high precision. You want the position of the real implant to match as close as possible the position of the virtual implant. So to illustrate this example, you can see an attempt to maximize the pedicle screw length, but on your post-op CT on the right, you could see what that would look like if you had a 4 millimeter anterior breach being potentially harmful to the patient. The FDA tells us that you need to have less than 3 millimeters and less than 3 degrees of linear and angular deviation, respectively, to be clinically safe. So to determine this, we calculated the 3D coordinate positions of all our virtual implants, as well as the 3D coordinate position of all our real implants, did a Euclidean deviation analysis, which is beyond the scope of this talk, but the results of this demonstrated excellent precision. We had a 1.98 millimeter linear deviation, as well as a 1.29 angular deviation, both of which were statistically significantly less than the FDA mandates. And those relationships held steadfast regardless of whether you're in the thoracic or lumbosacral spine segments. As a point of comparison, this data is not widely reported, but Kleck et al. Did report this in 158 pedicle screws in 2016 for the Stealth Stations version 7. And they demonstrated a 5 millimeter linear deviation and a 3 degree angular deviation as the systematic precisional error within that system. So in conclusion, confident that we've built a clinically accurate and precise novel navigation system It's very intuitive, has a low learning curve. It is now FDA approved, and we're going to be doing the first man use of this study at Hopkins in about 2 weeks. There's a lot of people like to think this, short 4-minute talk is about the culmination of 4 years of work that led to our FDA approval most recently, particularly the Carnegie Center for Surgical Innovation. My mentors, Dr. Shuva, Dr. Theodore, and Dr. Witham, and our recent collaborators, Dr. Phillips, Koo, Polster, and Coleman, who participated in our percutaneous pedicle screw insertion study. Thank you.
Thank you, Dr. Molina. Our next presenter is Dr. Kassam from the University of Calgary. Can you please share your screen?
There, can everyone see okay?
Yes, we can.
I'm phase 1 from Calgary. This is our study on cervical alignment in patients presenting with cervical spondylotic myelopathy. So cervical spondylotic myelopathy, I think we're all quite familiar with it. It's the clinical condition of, it's a result of cord compression from chronic degenerative changes in the cervical spine. Kyphotic alignment has been postulated to cause stretching and tensioning of the spinal cord, as well as flattening of the anterior cord over the vertebral bodies, as well as the discs and osteophytes. This has been shown in animal models to cause demyelination, apoptosis, as well as interrupted vascular flow. So it fits that kyphotic alignment should predispose to cervical myelopathy. However, we know that up to 1/3 of asymptomatic patients or people within the population do have kyphotic alignment between C2 and C7. So it's a bit unclear as to whether kyphosis in itself is a risk factor for myelopathy or perhaps a pathologic response to myelopathy. So we wanted to look at alignment in myelopathic patients and compare them to a healthy population. So we compared two different groups. That's the whole point of the study. There's 214 myelopathic patients with an average age of 62 years, 189 asymptomatic volunteer subjects. Notice their mean age was 28 years. So these are two different populations. We looked at the C2, C7 Cobb angle, T1 slope, as well as the cervical sagittal vertical axis. So the myelopathic patients all came from the CSRN database. They all had, this was based on their initial radiographic lateral upright imaging. And then the young volunteer patients all underwent EOS imaging, which is essentially a tool that provides a low dose of X-ray radiation and has perpendicular beams to one another with moving detectors. So it is an X-ray modality. I think we're all familiar with these measurements that we used. Here are the results. So in the myelopathic group, not surprisingly, they had a significantly higher sagittal vertical axis compared to the young healthy group. As well as T1 slope, the myelopathic group had an increased T1 slope relative to the young healthy group. But very surprisingly, when we looked at the C2, C7 Cobb angle, the myelopathic group actually averaged 7.5 degrees of lordotic alignment, not kyphotic alignment. The young healthy group averaged 2.5 degrees of kyphosis as opposed to lordosis. So that was quite surprising. And then higher positive sagittal balance, increased lordosis, not kyphosis, and higher T1 slope, all correlated with severity of myelopathy in the myelopathic group as gauged by the MJOA score. So in conclusion, at least in this patient population, our patients had a tendency toward lordotic alignment in contrast to the young healthy volunteer subjects who actually demonstrated a mild amount of kyphosis. So kyphosis may be more prevalent than we think, and perhaps we should be focusing on cervical sagittal vertical axis or sagittal balance, as well as T1 slope, as opposed to kyphosis as being a risk factor for the development of cervical myelopathy. So the big question that comes out of this, I think, is whether kyphosis in itself between C2 and C7 actually predisposes these patients to development of myelopathy. I think to further strengthen this study, we need to control for age and have an assessment of a similar age group in myelopathic versus asymptomatic subjects. And then we also need to look above C2, cranial to C2, as well as caudally to look at lumbopelvic alignment parameters, because we know that those will have an influence on cervical alignment. Thanks for your time.
That's excellent. Thank you very much, Dr. Kassam. So we're going to open it up to some questions and answers. And I just want to remind everyone right off the get-go to please use the little Q&A window down at the bottom and ask any questions along the way to any of the presenters. But just for starters, I was going to just start off by asking Dr. Pennycook, how did you train and test your predictive model?
So of the 411 patients, we split into 70% in terms of training the model, 30% of the patients to test, which is standard practice for any of these predictive models. We did some bootstrapping. That's how we were able to get the predictive intervals that you saw in my graphs, basically the shaded gray area. And ultimately, the R squared for the test model was around 62, which I didn't list here because it was outside, I think, the scope of this talk, but which isn't great per se, but shows that as we get more patients into this database, again, 411 patients for a random forest really isn't that many patients. But we're encouraged because we don't feel like we're overfitting to our training data. But basically, we split 411 patients, 70-30, train and test.
That's great. Dr. Molina, I mean, very impressive talk. Thank you. It looks like a lot of work for 4 minutes. One of my questions I wanted to ask is, what was the rationale for T5 to S1 for your instrumented levels? Did you, was there a reason for doing those? Have you done higher thoracic? Have you done cervical levels?
So the very plain reason is that we calculated an N number of screws that we needed to instrument to reach statistical significance on our precision data, which is what the FDA is interested in, not so much the clinical accuracy Gertzbein data. And when you place the clamp at L2, based on the 2 spins that we had to do for the thoracic and the lumbar using the arrow, that's the segments that we were able to instrument. So it was purely practical. Had we been able to, do more spins, we could have done more levels, but we didn't need any more based on what we had calculated pre-experimentally to reach our hypothesis. In terms of have we attempted upper thoracic and or proof of concept cadaveric studies, we've done up to C2 cervical pedicle screws. Thank you.
Dr. Kassam, it is interesting to see these different patient populations. And I guess the demographics being young versus old, what kind of impact do you think, was there a selection bias at all, do you think, in your results? And could you maybe explain how you controlled for that?
I think that's one of the limitations of this study is that there is significant selection bias, and the age groups are certainly different. So we did not control for that in this study, but I think that would be the next step. It's the main reason for doing that is that it's hard to get big numbers of age-matched volunteers to get imaging done who are asymptomatic as compared to the young, healthy population that we already have. But for sure, I think that would be the next step, is to actually control for age and look at myelopathic versus asymptomatic subjects within the same age group, especially because we know that cervical lordosis generally increases with age based on some recent studies. So it would be interesting to see whether asymptomatic older patients also share that increase in cervical lordosis, or whether they remain neutral or mildly kyphotic like the young patients.
Along those lines, Dr. Kassam, I'm going to ask a question from the Q&A. Dr. Smith brought up the good point that we know as we age, the global SVA increases, and that one compensatory measure is to increase your cervical lordosis. And so could it just be that this increased lordosis that we're seeing is related to the increasing overall alignment that's kind of moving anterior and not necessarily just focused on the cervical spine?
For sure, it could be, but in addition, to expand on that, it could also have to do with older people having increased thoracic kyphosis and even lumbar lordosis. Obviously, that depends on their pelvic incidence, but I do think that would be a valuable next step to look at. It's just with all these myelopathic patients, we don't have initial assessment 3-foot Scoli films, but that would be the ideal thing to look at, especially with older patients who have increased thoracic kyphosis. I do think a lot of this probably has to do with compensatory cervical lordosis as people age. But I think it's an important point about the positive sagittal balance or the SVA. I think this does tell us that perhaps while we're in the OR trying to correct alignment, we may want to look at global alignment preoperatively and account for that. And as well, perhaps we should focus a bit more on cervical sagittal vertical axis, as opposed to just looking at kyphosis versus lordosis. So for sure, it's a good point, and I think it's all obviously relevant and ties in.
Thank you, Felipe. Sorry, go ahead, Ryan.
Okay, we have time for one more from the Q&A. Just for Dr. Molina, really impressive technology. I guess the question becomes from Dr. Patel, the 2 to 3 millimeter range for tolerances is FDA driven, but is clinically maybe a little bit generous. Maybe you can comment on that. And then, in a world where there are so few symptomatic screws, maybe you can comment on the importance of this technology, given that symptomatic malplaced screws are fairly rare.
Thank you. That's a great question. So a two-part question. The first in terms of the FDA criteria of precision. So I agree. I found it a little bit difficult to kind of understand the clinical implication of 2 to 3 or whatever millimeter system they're using. So we first went out into the literature to see what the other conventional systems that people use today comfortably and confidently as a method of comparison. And we found that the data that had been submitted to the FDA was on 2-dimensional sawbones data to meet this 3 millimeter criterion, 3 degrees. And when the few papers that have reported 3-dimensional precisional data and clinical scenarios, they've demonstrated precisional data, for example, for the Stealth station, as I mentioned, 5 millimeters of linear deviation and 3 degrees of angular deviation. For the Excelsius system, Godzik et al. At the Barrow, they reported a 5 millimeter linear deviation as well and a 5.6 angular deviation. So as a metric of comparison in terms of what's considered the gold standard today, we found that we're favorable. But as I think a more important point is that these positional errors, they're never going to be zero. There's systematic errors that occur in any type of navigational system. And what's I think more important, regardless of what system you're using, is to know what the systematic error of your system is and to compensate for it. So to not be comfortable maximizing the pedicle screw length, or know how to ride safely if you're trying to put in a very straight small thoracic pedicle screw. Don't go for a very dangerous angle because you trust the system. You have to know what your system can and cannot do to use it in a safe manner. So these precisional errors are inherent to every system, and you just have to know what your systems is that you like to use and compensate for it accordingly. And then the second part of the question, which I think is incredibly important, is that there is an incredibly low rate of clinically relevant pedicle screw malpositions out there. And we didn't really develop the system to put in a better pedicle screw because, frankly, there's not a true need for that. That's not a problem that I think exists. What we really wanted to do was to create a system that got rid of those navigational pitfalls that I talked about at the beginning in terms of attention shift and line of sight obstruction. But really, we wanted to take a navigation camera and put it directly on top of the surgical field with not with the immediate goal of navigating instruments, but eventually to do more advanced navigational procedures such as computer vision and machine learning, which is something that a remote tracking camera will never be able to do. So right now we're working on surface matching to be able to guide navigation without any type of fiducials. We're working on osteotomy planning and osteotomy situations and things like that. So
perfect.
Thank you.
Yeah, so perfect. We should probably keep going. Yeah.
Thanks, Dr. Molina. So our next speaker, they're all great talks, and it's just tough to fit everything in our short period of time. So our next speaker is Felipe. He's from Northwestern. Felipe, can you please share your screen, and we want to hear your talk there.
Can you guys see the slide?
Yes, we can.
Okay. Thank you for selecting my research to be presented here this evening. My name is Felipe Duarte. I'm a spine fellow at Northwestern, and I'll be speaking to you guys about predictive analysis of the utilization of healthcare resource after elective spine surgery. A little bit of the background information. Healthcare utilization is estimated to be about $226 billion per year, according to some studies. There's increasing efforts to predict high utilization, which are becoming of increasing importance in modern surgical practices. The purpose of our study was to identify predictors of health resource utilization after elective spine surgery in a consecutive series of patients. This was an IRB-approved study. It was a retrospective review of all patients who underwent elective spine surgery at a tertiary academic medical center. All patients were treated by one of 3 fellowship-trained spine surgeons. And the inclusion criteria was a diagnosis of lumbar and cervical degenerative pathology, as well as at least 1-year follow-up. We excluded all patients who had adult spinal deformity as a diagnosis. Some of the data that we collected were demographics, ASA, BMI, Charlson Comorbidity Index, and the complications that we looked at specifically were acute kidney injury, acute MI, AFib, anemia, delirium, DVT, hypotension, pneumonia, PE, sepsis, stroke, urinary retention, UTI, and wound complications. Specifically for the healthcare utilization categories, we looked at advanced spine imaging, surgery-related and non-related, urgent care and emergency department visits, reoperations, PT and OT referrals, opioid refills, epidural steroid injections, referrals to other services, pain management referrals, as well as acute inpatient rehab referrals. And we looked at these at the 30-day, 90-day, 180, and 365-day postoperative time points. As far as our results, we ended up with 624 patients that met the inclusion criteria. Their average age was 57 years old, their BMI was 28, and their CCI score was 2. Most common diagnosis was lumbar stenosis, lumbar disc herniation, as well as cervical stenosis. Complications were reported in 43 or 7% of our patient population. And at the 1-year mark, the reoperation rate was 3.8%. We did a univariate analysis for complications. This was controlling for age and BMI. And although there were multiple of the categories that had some interesting findings, the only one that reached statistical significance was acute kidney injury within 30 days. We noticed that this occurred at 1.6% rate in those patients with a CCI less than 3, about 3% of those with CCI of 3 or 4, and 10.5% of those with a CCI greater than 4. It didn't happen in anyone with ASA of 1, 2.6% in ASA 2s, and about 5.5% in ASA 3s. As I mentioned before, the complications did not achieve statistical significance, in part due to low occurrence rate in our patient population. We also did a univariate analysis for healthcare resource utilization, again, controlling for age and BMI. And this was table 2 in my poster. I'll summarize the findings in the following bullet points. We noticed there was a 12% increase in emergency department visits per each 1 point increase in CCI. And there was almost a 5-fold for ASA 3s. Narcotic medication use at the 1-year mark was increased by almost 17% for each 1 point CCI increase. Nerve stabilizing agents were up 1.8-fold for those who had ASA of 2 and almost 2-fold for ASA 3s at 90 days, and then 6-fold for ASA 3s at the 1-year mark. Referrals to pain management were up by 9% for each 1 point CCI increase. Referrals to other services up by 12% for each 1 point increase in CCI, 6-fold increase for ASA 2s and 10-fold for ASA 3s. And finally, referrals to acute inpatient rehab was up by 21% for each 1 point CCI increase and 2.5-fold for ASA 3 compared to ASA 2s. A more graphical representation of the CCI data. For each 1 point increase, you get the following percentage in the respective categories. So in conclusion, the study identifies patient-based factors which correlate with higher healthcare resource utilization. Some positive predictor factors included CCI and ASA scores. As a pilot study, this gave us pretty good initial information, but ultimately what the study needs going forward is a multivariate analysis of CCI subcategories to see if one plays a more significant role than others, as well as expansion to either multi-center collection or expansion of our own patient population here at Northwestern, or switching over to a database system. Ultimately, we're looking to do with this is expand and refine the information, try to develop some sort of an algorithm that will guide patient selection and primarily identify those who will need significant preoperative optimization in order to minimize healthcare resource utilization. Thank you.
It's a great talk, Felipe. The next presenter is Dr. Maslick from the Cleveland Clinic. Dr. Maslick, can you please share your screen with us? So again, just while the screen's coming up, please keep the question and answers or questions coming. We've got Ryan on the hot seat. He's busy giving everyone some feedback. Is everything okay, Dr. Maslick, with your presentation?
There we go.
There, I can see it.
Everybody
Go
hear
ahead.
me?
Yes.
All righty. So my name is Joe Maslak. I'm one of the spine fellows at Cleveland Clinic with Dr. Savage and Miraz. Having an incredible year so far. I'd like to thank the AO for giving me this opportunity, and I'd specifically like to thank Chief for kind of organizing all this. I know she's put in a lot of work. I'm going to present a study today on lumbar spinal epidural lipomatosis. This is a condition characterized by the scallop sign on MRI. And I'd like to thank my senior authors, Drs. Patel and Sue from Northwestern, for all their work on this study and their mentorship. We have no relevant disclosures. So spinal epidural lipomatosis is an excessive deposition of benign adipose tissue within the spinal canal. While multiple classification systems have been proposed, they all have their issues. The morphologic Y sign, characterized by its symmetric fecal sac compression on the axial MRI, tends to underpredict this, as found in studies that look at the proportion of epidural fat in the spinal canal. Absolute thresholds may actually overestimate SEL because, again, they don't necessarily take in the proportion of epidural fat in the canal. And then prior research, the research that's quoted most specifically and most frequently tended to focus on L5S1, and they actually labeled it lumbosacral epidural lipomatosis. So their methods, which have kind of been borne out throughout the literature, may actually be describing a different entity entirely. So these earlier descriptive reports of SEL may have not captured the true SEL population due to their diagnostic criteria or study design. And quoted prevalences have ranged from 2.5% to 8.6%. So a rare condition, but it's something that we will all see throughout our career. So the purpose of this study was to redefine the diagnosis of SEL using a systematic retrospective analysis. So we constructed a single institution retrospective database of adult lumbar MRIs, excluding those patients with diagnoses of coexisting compressive pathologies such as facet cysts, disc herniations, epidural hematomas, abscesses. And then we reviewed all these MRIs to define our patients with SEL. And we defined SEL as an anterior protrusion of posterior epidural fat over at least 2 levels. You can see this is indicated by the solid line in figure A, with the transitions from segment to segment as indicated by the dashed lines. And we refer to this posterior epidural fat drapage as the scallop sign. And this is easily identifiable on the T1 sagittal MRI. You can see a control MRI on the right in figure B there. Our secondary characteristic we used to define SEL was greater than 1/3 of epidural fat occupying the canal on our axial at the disc level over 2 levels. And then once we identified these patients, we compared them to age gender matched controls. In both the SEL group and the control group, we performed measurement analysis. You can see in figure A, we measured the posterior epidural fat at both the disc level and the mid body. In figure B, you can see we measured the canal A to P diameter, again at both the disc level and the mid body. We measured the pedicle lengths, and then we calculated the epidural fat index, which is the percentage of epidural fat at the disc level over the mid body level. So we had over 800 MRIs, including 571 patients. When these were all reviewed, 71 patients met criteria for SEL. You can see that compared to the controls, these patients with SEL had similar age, BMI, and height. However, they were found to have statistically significant increase in weight. Those patients with SEL were found to have significantly higher percentage of epidural fat at the disc level from L2 to L5, as well as the mid-body from L2 to L4. And the epidural fat index was 1.8 times higher on average at the L2 and L3 levels in those patients with SEL. So our study, our case series found an overall incidence of 12.4% of SEL. We identified patients with significantly increased epidural fat occupation across multiple vertebral levels at both the mid-body and intravertebral disc. Moreover, the ratio of fat occupation was about twice as that of the control group. We defined this draping pattern of epidural fat as the scallop sign, and this is easily distinguishable from the T1 MRI. This discernible morphology of epidural fat may provide insight into clinically relevant SEL, and further research investigating symptomatic patients can further characterize the natural history of this phenomena. I'd like to thank everybody involved.
Thanks very much, Dr. Maslach. Our next speaker is Dr. McCarthy from HSS. Dr. McCarthy, can you please share your screen with us? This is, by the way, our last presenter of 3, and then we're going to break off into questions after this. I can see your screen. Go ahead.
Great, thank you. So I'm Mike McCarthy. I'm at HSS. I want to give a special shout out to Joe, my former co-resident, so I'll try to follow his lead, and also to my fellowship director, Hanjo Kim, who's on the line with us. So my study is how much lumbar lordosis does a patient need to reach their age-adjusted alignment, and kind of coming up with a formulated approach to assess that. I have no relevant disclosures with this one. So age-adjusted alignment targets have the potential to reduce incidence of PJK and also ensure optimal health-related outcomes for our patients. We know that lumbar lordosis and thoracic kyphosis has been recently studied and highlighted in a variety of new studies, and especially this equation that I put here is one of the most recent ISSG studies used to find and solve for lumbar lordosis and also thoracic kyphosis. We know that the clinical application of regional alignments is somewhat difficult, both for individual patients, but also balancing thoracic kyphosis and lumbar lordosis and predicting what we need to achieve. And we know that most of the equations that we have right now are somewhat simplistic and really don't account for either one of those. And also, more importantly, don't really account for age-adjusted parameters that we know play a significant impact. So the objective of our study was to identify optimal lumbar curvature in adult deformity and also the correction needed to achieve sustained alignment. So this was a multi-center retrospective review of a prospective database. So we looked at the ISSG database, included patients with adult deformity, looked at pre and post-op clinical data. As you can see, it had a variety of factors of BBL, osteotomies, interbodies, and a variety of other ones. We looked at patients specifically reaching age-adjusted ideal alignment at 1 year post-op. So those patients alone were the ones who were meeting our inclusion criteria. We looked at multiple demographic information, and also spinal pelvic parameters that we all know, specifically the physical pelvic tilt, PI, PI-LL mismatch, TK, TPA, and SVA. And we looked at all of these parameters on standing films. So we did a basic statistical analysis of our demographic of our cohort, and also pre and post-op analysis. For the lumbar lordosis and thoracic kyphosis, we did a multilinear regression to identify the relationship between those two parameters. And then we also looked at the correlationships permitting a global alignment using TPA based on pelvic incidence. So we had 347 patients meeting our inclusion criteria. We noticed a significant improvement in all of our sagittal parameters from pre-op to 1 year post-op. We also found a significant prediction for lumbar lordosis based on thoracic kyphosis, TPA, and pelvic incidence with an R-squared of 0.85. We also found that TPA percentile groups demonstrated excellent prediction of lumbar lordosis. You can see those R-square values range between 8.3 and 8.7. So this graph here is patients matching age-adjusted TPA targets stratified into TPA percentiles and then categorized. And so you can see those in the less than 25 percentile range we deemed very low. The next one was low. The one between 50 and 75th were medium, and then the one above that we deemed a high TPA. So using that and then the simplification of coefficients of prediction allowed us to create this initial formula, as you can see here in red. And so we internally validated this one with based on our patients with age-adjusted alignment And we found that there were similar accuracies across the entire spectrum, as I showed in that graph, that table before. All the patients in that or throughout that entire age-adjusted spectrum were validated using this formula. We then converted an age-based formula, and then we're able to produce the last equation here in red: lumbar lordosis equaling PI plus 0.3 TK minus 0.5 age plus 10. So in conclusion, age-adjusted parameters really are kind of difficult to kind of understand, both in the specific spine regions, but also the interplay between each one, and also the pelvic morphology, and how that also has an impact on predicting these alignment targets for our patients. And most of the studies that we've seen today, or to date, and also the equations that are out there, are kind of simplistic and don't really account for these multitude of factors. So our study identifies patients who had optimal surgical outcomes, and accounting for thoracic kyphosis, TPA, and PI, and in predicting lumbar lordosis, and all these, which really produced excellent results for us. And so what we offer is this kind of more all-encompassing formula to kind of lead to an age-based formula to both find thoracic kyphosis and lumbar lordosis. And so we feel like this could be really helpful in reducing suboptimal alignment outcomes in our patients, and account for these multitude of factors that impact that. Here's some of our references. Thank you very much.
Excellent. Excellent. That's a great study. I think we're going to take a few questions. So I'll start with Dr. Ituarte. Really a great study. One question that came up in the Q&A was from Dr. Dobbs, who's done some work on some of the psychosocial factors that influence outcomes and healthcare utilization. And his question was, did you look at mental health scores in your analysis, and what impact could that maybe have if you did?
Yeah, that's a good question. And I've seen research along those lines, and I know that it plays a significant factor into this, but we did not have this included in the initial data set that we had as far as like a mental health questionnaire. As far as psychosocial, the only thing that may have been included to some extent would be dementia factored into the CCI score, but really no other mental health diagnosis or questionnaires. It would be pretty good to include that in the final study.
Yeah, something to consider moving forward. Really a well done project. And then a question for Dr. Maslach. The scallop sign, it's easy to remember. It's a great study. I think, it's something that people struggle to do is defining when it's pathologic versus physiologic. One question that came up in the Q&A was about possible neoplastic features of epidural lipomatosis, and maybe you can comment on if you've sent any of it for pathology or what you think about that.
I think that's a fascinating question, and I have not sent any of it for pathology yet. I think the goal of this study was to kind of identify our population, especially given the kind of lack of clarity in the prior literature. So I think that now that we have this population, I think it's a great idea to send out specimens and to see and to kind of see over time if this is something that gets worse with time, or if this is kind of a static thing.
Yeah, well done. And then one question for Dr. McCarthy. I love the simple formula. It seems relatively easy to use. Have you incorporated it into practice at your institution? And then have you considered, the location of the lumbar lordosis that was brought up, I think, by Dr. Smith, as that may impact outcomes as well?
We have started to kind of utilize this in the fall is when we kind of came out with this, and it's helpful intraoperatively as we start to kind of think about, gauging where you are as far as your correction. Are you achieving what you need to achieve? And also, obviously, with preoperative considerations, that's probably the most ideal utilization of it. We are kind of starting to think about it more, and also incorporate it more into our preoperative and also intraoperative planning. To address Dr. Smith's question, we didn't really. It's really good point. We noted some of the apex of the deformities, but we never really incorporated that fully into the study. And definitely something that we can incorporate. So thank you.
Excellent, thank you.
Thanks, Ryan, for bringing up a lot of those Q&A questions. Please keep them coming. I noticed one more here by Dr. Failings. He was asking what Felipe thought he felt might be one of the key confounders in his analysis. I'm not sure if he can comment on that.
I would say maybe shifting it over to limitations. I would think the biggest limitation for the study, what we have so far, is the fact that it's a retrospective review. And although we try to be fairly comprehensive with the chart review of 604 patients or so, we probably had maybe 60 to 80 data points per patient over the course of that year that we had to go in through the chart and dig through. Some of those things may be hidden deep in some note, or if a complication wasn't coded accurately, we may have missed it to some extent. So I would say that's probably its biggest limitation, the fact that data could have been overlooked.
Thank you very much for that. So we're going to move into our last panel. We have 4 speakers now. We're going to start with Dr. Karim from UBC. Dr. Karim, can you share your screen with us, please?
Absolutely.
Good, I can see your screen and I can hear you. Go ahead.
Okay, perfect. Thanks everyone for having me. I'm Mohammed. I'm one of the spine fellows here in Vancouver. I'm going to be sharing the data from the Canadian prospective cohort study on cervical myelopathy and the efficacy of surgical decompression for cervical spondylotic myelopathy. Nothing to disclose on my end or for any of the authors that are part of the CSOR network for this paper. So we're all very familiar with the disease process of cervical myelopathy, of course, and we know the treatment is broadly in either aimed at either surgical decompression or observation. And of course, we also know that there's a wide spectrum of disease severity in myelopathy, from some patients with just simple mild dexterity issues and sensory changes to other patients who are quite debilitated with severe myelopathy to the point where they can't ambulate or can't control their bowel or bladder function. So I wanted to briefly review the existing evidence on surgery in terms of its efficacy for cervical myelopathy. And the only level 1 evidence is actually a paper from 2000 from the Czech Republic and RCT that compared surgery and conservative management for cervical myelopathy in a group of patients with mild to moderate myelopathy, and found no significant benefit to surgery after 2 years of follow-up in comparison to the non-operatively managed group. So the only level 1 evidence was that. And then about 7 years ago, the AO Spine group published their data that was a prospectively collected multi-center cohort study between the United States and Canada that looked at outcomes among all patients with cervical myelopathy across the entire spectrum of disease severity, and found different results in that patients improved in all of the severity categories, regardless of what their baseline disease severity was. And then the actual AO Spine clinical practice guidelines strongly recommend surgery for both severe and moderate myelopathy, but there's a weak recommendation for either surgery or observation for patients who are mildly myelopathic, which sort of highlights the discrepancy in the evidence a little bit, especially for that group. So the purpose of this study was really to validate the prior data from AO and perhaps some of the other retrospective studies, looking at what the efficacy of surgical decompression and cervical myelopathy was in an independent cohort of patients. So CSORN is a group of centers throughout Canada who prospectively collect data on various spinal pathologies. So for the cervical myelopathy cohort, 7 separate centers have been prospectively enrolling patients since January 2015. And this particular cohort, we selected a 4-year period from 2015 to 2018. 35 surgeons were involved, and all patients had clinical features of myelopathy in addition to cord compression on their MRI. The outcome measures we were interested in were the MJOA score, since that's sort of widely accepted as probably the most commonly used outcome measure in myelopathy. But we also wanted to include other ones, including the Neck Disability Index, the EQ5D, and the SF12, to further broaden and capture maybe some of the other improvements, since we know there are some limitations to using the MJOA score. And then we stratified patients in the cohort based on their disease severity, based on these accepted MJOA scores for severity, as you can see here. So the cohort ended up consisting of 391 patients. You can see how many were in each group: mild 110, moderate 163, so on. The average age I've highlighted here is about 60 years of age. Also highlighted of interest, about over half of the patients in the cohort were treated posteriorly, and the average number of levels that were decompress were between 2 and 3, 2.76 here. So this is the crux of the results. So we'll start with just the MJOA score. And you can see here that if we look at the outcomes of surgery by disease severity from baseline on the left to then 3 months and then 12 months after surgery, we see there's essentially no significant change whatsoever in the mildly myelopathic patients, whereas the moderately myelopathic patients do see an improvement in their MJOA scores that was statistically significant, but didn't actually meet the NCID for moderately myelopathic patients for improvement. It was really only the severely myelopathic patients that actually showed both a statistically and a clinically significant improvement in their MJOA scores. And that's highlighted by that star here. But what about the other outcome measures? What about the patient-reported outcome measures? So if we look at the Neck Disability Index, in which lower scores indicate better outcomes, we see completely different results in that all severity groups actually improved significantly. The mild group, the moderate group, the severe group, and the cohort as a whole. Similarly, if we look at the EQ-5D, we see statistically and clinically significant improvements across all the disease severity groups. And finally, also the SF-12 physical component score, we similarly see improved outcomes at 12 months after surgery across all the disease severity groups. So that's just summarized here. What we can see with all the outcome measures is that the severely myelopathic patients improve across all the outcomes measures, whereas the mild and moderate patients don't improve in terms of MJOA, nor in terms of mental health, but they do show statistically and clinically significant improvements in the Neck Disability Index, the EQ-5D, and their physical function based on the SF-12. So in conclusion, we found improved outcomes with decompression and cervical myelopathy across all disease severity groups, with the magnitude and breadth of improvement being directly related to how severe the patient's baseline disease severity was, and sort of also highlighted the limitations of the MJOA score in particular as an outcome measure, given its ceiling effect, particularly in patients with mild myelopathy. I think what would be particularly interesting from the CSORN cohort in particular is that non-operatively managed patients are also being recruited and data being collected. So in the future, we'll hope to have a comparison between operatively and non-operatively managed patients, especially with those with mild disease, to see if surgery is making a difference in comparison with conservative treatment. Thank you all very much.
Thank you, Dr. Karim. Another nice talk. Our next speaker is from the University of Calgary, just down the street from Banff. It's Dr. Evan View. Can you please share your screen with us, please? Great, I can see it.
Yes, all right, very good.
And I can hear you.
Okay. Okay, thank you for the opportunity to present this work. Interestingly, this study comes from the same data set that Dr. Karim just presented, from the same collaborative group of Canadian investigators, the Canadian Spine Outcome and Research Network. We here present an adjusted analysis of clinical predictors of achieving the minimum clinically important difference in the MJOA after surgery for myelopathy. Many of you may be familiar with this recent literature on this topic published from the AO Spine North America and international cohorts. This series of observational studies investigated just this, factors associated with improvement by at least the MCID for the MJOA. These are high quality papers, they're best available evidence. However, they've not yet been reproduced elsewhere. External validation is an essential part of the scientific method and a part of evidence-based medicine. So in order to optimally inform shared clinical decision-making, we performed an external validation study using this CSORN CSM prospective data set. Our research question: in CSORN patients undergoing surgery for CSM, which preoperative clinical factors, patient characteristics, not MRI, not technical factors, are significantly associated with improvement on the MJOA by at least the MCID at 12 months of follow-up. We implemented current best thinking about the MJOA and the MCID, whereby patients with mild disease must improve by just 1 point to achieve the MCID, in comparison to patients with moderate or severe disease who must improve by 2 or 3 points respectively. We identified at the time of this analysis a cohort of 205 patients that had clean data. We had a reasonable distribution of mild, moderate, and severe. We found that half of all patients operated on for myelopathy improved by at least the MCID. But interestingly, we noted differences according to baseline disease severity, whereby patients with milder disease were less likely to improve by the MCID in comparison to moderate or severe. This held true even after adjusting for potential confounders in our regression analysis. Here we found that older age and milder disease severity were associated with a reduced likelihood of improvement by the MCID. In contrast to previous literature, smoking status and symptom duration were not significantly
Can you just mute your
associated.
phone, please? Your mic, I think it's Mohammed.
Right, yes. In conclusion, we found that surgery is effective in these patients, half improved by the MCID. Patients with older age and milder disease were less likely to improve. Symptom duration and smoking status might not be as important as previously thought. And we do note several limitations to this study as well. Thank you.
Great, thanks very much. So our next speaker is Dr. Shorten. Dr. Shorten, can you please share your screen with us? Dr. Shorten's coming from the University of Utah. That's perfect, I can see your screen, go ahead.
Perfect, thank you. My name is Peter Shorten. I'm from the University of Utah. My research is on risk factors for postoperative ileus in patients undergoing spine surgery. I'd like to thank my faculty mentors listed below. I have no relevant disclosures. Postoperative ileus is the transient loss of coordinated bowel motility after surgical intervention and is characterized by certain clinical hallmark features, including abdominal pain, distension, bloating, nausea, vomiting, a delayed passage of flatus and stool, and an inability to tolerate oral intake. And all of these things ultimately result in an increased length of stay, higher hospitalization costs, higher hospital readmission rates, and all of these things are important for the surgeon, for patients, and for hospital administrators. In the spine literature, what we found is that the incidence of postoperative ileus ranges between 2 and 7.5%. There's a lot of inconsistency, however, in the risk factors that are identified in these studies. And the reason for that is because we're really limited to small retrospective studies or large database studies, which we know the limitations of well. And interestingly, despite the well-known association between opiate use and GI issues, there's really just one study that's in the spinal literature that's looked at intraoperative and postoperative opiate intake on developing postoperative ileus. So with this in mind, it was our intention to look back at the University of Utah's database and to report on the incidence and as well as the risk factors for developing postoperative ileus in patients undergoing thoracic and lumbar posterior instrumented fusion, specifically looking at intraoperative and postoperative opiate consumption. We conducted a retrospective review of patients who underwent posterior thoracic and lumbar fusions in a 2.5-year period. We identified these patients using CPT codes and then a thorough chart review. Postoperative ileus was determined based on the clinical findings that we determined in the chart and confirmed that with abdominal radiographs. Trauma and tumor patients were excluded. We collected a variety of patient characteristics as well as surgical parameters with a specific emphasis, again, looking at intraoperative and postoperative opiate consumption, which was converted to morphine milligram equivalent units. Our primary outcome was the development of postoperative ileus. There were 762 patients who met our inclusion criteria, 60 of which developed postoperative ileus, resulting in a 7.6% incidence, which is consistent with some of the previous reported data. What we did find was that patients undergoing a fusion of greater than 3 levels were significantly more likely to develop a postoperative ileus. And interestingly, younger patients were also more likely, which is a bit different than some of the previous literature. We also found that those patients who ultimately developed postoperative ileus were in the hospital for a significantly longer length of time. When looking at some of the other patient characteristics that we evaluated, there was no difference between the groups. And looking at some of the surgical parameters, including interbody fusions, posterior osteotomies, EBL, and total anesthesia time, we also didn't find any significant difference between the groups. When looking at intraoperative as well as postoperative opiate consumption, when you look at the different medications that were administered, there was really no difference between the groups, as well as the total intraoperative opiate administration, as well as the cumulative 24-hour post-op opiate consumption. In our multivariate analysis, only the number of levels fused were found to be statistically significant. So in conclusion, what our study found is that patients undergoing thoracic and lumbar posterior instrumented fusion of greater than 3 levels are far more likely to develop POI. And interestingly, the total intraoperative as well as postoperative opiate consumption over a 24-hour period of time was not found to be a significant risk factor for developing postoperative ileus. These are my references. Thank you very much.
Thank you, Dr. Shorten. So our last presenter now is Dr. Yerner. He's from University of Virginia. Can you please share your screen? Do we have Dr. Yerner there? Perfect. I can see your screen. Go ahead. We can't hear you.
Can you hear me right now?
Now, yes, we can. Go ahead.
Yeah, okay, perfect. So thank you for the introduction, Dr. Weber. And I would like to thank North America Spine for giving the opportunity to present here. My name is Ulaşşener, originally from Istanbul, Turkey, completed my residency in Istanbul. Currently, I'm a spine fellow in University of Virginia. And I also would like to acknowledge my co-author, Thomas Buell, and Dr. Smith for presenting this study. Sacral insufficient fractures after lumbosacral arthritis is an uncommon complication, and I'm gonna present today our operative experience managing this complication and propose a preliminary treatment algorithm on grounds of relevant literature. Starting with a brief background, the literature describing sacral insufficient fractures after spine surgery is rare, and these are mostly confined to case reports and small center cohort studies. Incidence range change between 1.2 to 14.5, and the high incidence rates correspond to studies with long fusion constructs, suggesting that construct length as a potential risk factor. Other potential risk factors include poor bone quality, advanced stage at prior radiation therapy. Symptoms can be non-specific and insidious. Here's a schematic picture of the major classification systems, Dönitz, Roig-Camille, and Kukla. Our study design is a retrospective cohort study with a time span of around 9 years, from 2009 to 2012. We include all patients with sacral fractures after lumbosacral arthrodesis who underwent operative treatment. Patients with sacral fractures caused by high impact trauma, infection, and tumor were excluded. Minimum duration of the follow-up or study inclusion was 6 months, and diagnosis of the fracture was based on CT imaging. The study design, we collected the demographics, comorbidities, lumbar spine surgery history, index, lumbosacral arthrodesis, bone quality, clinical symptoms, and radiological measurements. Our outcome were clinical measurements, radiological measurements, and post-op complications. The study cohort consisted of 9 patients with a mean clinical follow-up around 35 months. Mean patient age was 73, BMI was 30, and mean pre-op pelvic incidence was 69. Poor bone quality was the most common comorbidity, and index spinal surgeries were performed for spinal stenosis in 5 patients, PGK in 2, and degenerative scoliosis and high-grade spondylolisthesis in 1 patient. Our study has many of the previously mentioned risk factors like advanced stage, prune bone quality, and long lumbosacral fusions. All patients presented with persistent back pain and leg pain. In addition, 3 patients has neurological deficits, and for 7 patients, symptom onset was within a month after the index spine surgery. All sacral fractures were in Danish zone 3, and salvage surgeries were performed via posterior-only approach with distant extension of instrumentation. In 8 patients, we used bilateral dual iliac screw fixation. After the surgery, pre-op back and leg pain and lower extremity weakness improved after surgery for all patients. And radiologically, mean structural fracture anterolatesis improved from 8 millimeters to 4, and kyphotic angulation improved from 11 degrees to 5 degrees. And 2 patients required revision surgery for rod fracture. Based on our study results and literature review, we proposed a management algorithm for treating sacral insufficiency fractures. A period of approximately 6 months for non-treatment may be reasonable. It's giving time for allowing healing. And non-treatment includes bracing, activity modification, pharmacological time. And during this time, if the pain persists or worsens, interval imaging should be performed because this could represent increased fracture displacement. When it comes to surgical treatment, if there's persistent pain after a full trial of management, it should be reasonable. In conclusion, sacral insufficiency fractures are uncommon posterior complication after posterior instrumented lumbosacral arthrodesis. Affected patients commonly complain of persistent back pain and sacral tenderness. Fracture usually occurs within a few months after surgery, and CT imaging often needed to make the diagnosis. And lumbopelvic fixation with bilateral dual iliac screws can effectively salvage the index lumbosacral fusion. In addition, this allows sacral fracture healing and improve clinical symptoms. I have no disclosures. Thank you.
Thank you very much, Dr. Urner. Quick question for you, just while you're still there. How many of these patients had significant neurological sequelae like Kodak 1, and how many of them improved?
Actually, they don't have caudal equine symptoms. I'm gonna pull up again. So 3 patients have here and here. 3 patients have external EHL weakness. It's 1 out of 5, and after the surgery, they all improved.
Great. So we have about 5 to 7 minutes maybe of additional questions. We're almost 12 minutes after 9. I appreciate everyone staying a little bit late. So just to respect everyone's time commitments, I'm going to let Ryan take over with some summary questions of some of our participants. And so Ryan, maybe if you don't mind, I'll let you take it away.
Perfect. Yeah, we'll try and keep it brief here. Dr. Karim, great study. The ceiling effect and the floor effect of the MJOA is something that we've studied here at the University of Utah, and I know it's been studied many places. Dr. Patel asked if your study has made you consider other outcomes measures because of the effect that you saw in your study.
Absolutely. I think that increasingly we're seeing numerous studies from numerous institutions coming out questioning the utility of the MJOA score as being used as an outcome measure for patients undergoing surgery for myelopathy. I think it's important in the era of patient-reported outcomes for us to be thinking about a wide variety of patient-reported outcomes. And clearly we're showing that if you use those metrics, you're getting more fidelity, you're getting more signal, essentially showing that patients are potentially improving across aspects of their symptoms that you may not be picking up by just measuring the MJOA. So for sure, I think other outcome measures are important.
Excellent. And Dr. Falings had a great question about the length of follow-up and the percent follow-up, which I also did not catch in your presentation. Do you have that information?
Yeah, I probably spoke too quickly. So there was a 12 months of follow-up. We'll certainly look forward to presenting the 2-year data as well. But that was in keeping with the AO Spine's initial publication of 12 months of follow-up data. And it was about 76% follow-up rate in terms of outcomes at 12 months, which is about 10% lower than the AO Spine cohort that was in the 80s. So not bad, not the best, but at least we're at just north of 75%.
Excellent, excellent. Thank you. Great study. Dr. Shorten, there is a question. As surgeons are taking on more financial risk with, bundles and value-based care, certainly having an ileus changes that equation. Is there any formula for minimizing this complication in those that are found to be at risk if we identify them?
I think that's one of the questions that we're trying to figure out with all of this, and part of that is trying to determine, and part of the study was, do intraoperative and postoperative opiates really change that? And I wonder if our attention to multimodal pain control has, in some respects, contributed to the relatively low incidence. And I would be interested to go back and look, the previous 5 years to see if there was a big difference in that. But other than utilizing other medications and to have an aggressive bowel regimen, beyond that, I don't think that anyone has a great idea what causes it and how to prevent it.
Yeah, certainly something that deserves more research. So great job on that. And then Dr. Evanu, another question from Dr. Falings, again about the MJOA, thinking about alternative outcome measures, maybe your perspective on that.
Yes, the MJOA is imperfect, but it is currently the most accepted outcome measure in CSM research, and the psychometrics are reasonable. Dr. Faling's question appropriately suggests that it might not be appropriate for patients with mild disease. I'm in agreement with that. I think most people are. It's been established that the MJOA is susceptible to ceiling effects. It's also been established that it might have limited correlation with patient-reported health status. It's probably not appropriate for detecting subtle changes in gait instability or hand dexterity amongst these patients with mild disease. Fortunately, there's a lot of exciting research now with modern technology looking at gait analysis and robotic or computer-assisted tests of subtle changes in hand dexterity. So I think the future is very, very bright in this area.
Great, excellent, thank you. I think with that, we'll wrap it up. Dr. Weber?
Yes, excellent job. Thank you, my co-mentor. And most importantly, thank you to all the great fellows' presentations. Thank you for all our participants. We had close to 100 people. It was really great to see. So have a great evening, and looking forward to seeing you at the next events that we've got scheduled. All the best.